tissues. But Anne-Marie.
Well, most of all, it's important when you renovate. Why do you do it? Because if you use graft material, it's for osteoconduction to stabilize the blood clot. Because if we don't stabilize the blood clot, we have a shrinkage and we don't get any new bone. If we have the patient kept asleep for several months, we can build a lot of bone. But in my hands, at least, from the studies I have, there were no clinical difference with or without the membrane, the resorbable membrane. I did the review. I saw when we have a non-resorbable membrane, there were a lot of exposures and infections, and you had to remove it. That's why we took the strategy of a resorbable membrane, because I got a lot of exposures, but then I could just easily remove the exposed membrane. And that was, as I saw it, an organized blood clot with graft material.
But at the end, around implant, are we regenerating bone?
In fact, from the submerged study, I after 6 months, I opened up to insert the abutment, and I could see in some patients there were for sure graft material. And in some, there were more bone structure. So it was very individual. What I could see on the radiographs, that was after 2 years, there were more defect fill on radiograph. I had more radiopaque structures. And of course, when you have a case after 10 years, what is it? I think it's a lot of graft material with bone around, but does it matter? I don't know. So that's my opinion. As long as it stays stable, it's more like a cork in a wine bottle, that it stays there. I don't want to have any infection. And the patients are very motivated. Periimplantitis patients are so motivated, more motivated, in my opinion, than periodontitis patients, because they know the history of losing teeth, getting implants, and now they are at risk of losing their implants. So they are so afraid, and they cooperate more or less, all of them. But I showed a case with no cooperation, and I would have had a different strategy in that case. No smoking is or less maybe a few cigarettes, but no generation in smokers.
And Serhat, what is for you the main differences then between periodontal and peri-implant regeneration?
First of all, I want to be on the secure side. This site is not gingiva anymore. This site is mucosa and undergone with the several wars of the implant placement surgery. Even if it's refined, they're not going to get 100% reproduction of the collagen inside. So we mostly encounter with the scarred tissue, receive the titanium, and then the crown, and then get the periimplantitis. So to me, the story is getting harder in terms of reconstruction point of view, because I depend all the time on the primary closure. If it's not primary closed, forget about everything. Maybe that's why she doesn't want to complicate by placing a barrier membrane. Maybe the xenograft will be more than enough to just fill up the defect. And the second part, to me, is when I was in the dental school, I was told about this is avascular root surface, avascular root surface. And avascular root surface, to me, is completely different environment when we're talking about dental implants versus the natural tooth. I would like to discriminate this: avascular and biocompatible, avascular and maybe biocompromised. So in that biocompromised situation with the titanium surfaces, we have many strategies, but I'm very secure since the 70s with the gray security and ultrasonics. That's why even that I showed a very, very severe one to be saved. But for the periimplantitis, you are working in a really difficult environment for the reconstruction point of view. This is a very tough question, but I hope I elaborate my clinical.
So is then to summarize, it's like the decontamination of the implant surface that is the main challenge?
Of course. And also the environment might flap. I depend on the flap, and this flap is from mucosa, not from my gingiva. And also, in my periodontal wound, I have the periodontal ligament cells. We have totally different ideas when we are evaluating, for example, the radiographic bone fill in the periodontal studies. Bone is for the GBR, but for the periodontal reconstruction, the main actor is the periodontal ligament cells. That's why Emdogain is a highly boosting material. We're just adding the biomaterial, xenograft or allograft, just to stabilize the scaffolds or keep in the space. The main actor is the periodontal ligament.
Yeah. And talking about Emdogain, is it in every cases then?
If I have the possibility, yes.
Good.
May I add? I always use Emdogain in periodontal surgery. Yes.
I second your.
Take your microphone, maybe.
Yeah, I agree. That's that one.
No, it won't.
No. Are you cheating me?
No, it's on. Yeah.
Yeah, no,
You can carry now.
yeah. No, I agree with you. I use Emdogain on all of them, but I don't use xenograft. I'm sorry. I'm sorry. I've been listening to you. My career was on peri-implantitis. You don't know that, but since 1997, I've been working on it. The decontamination is the most important point, and you mentioned it before, and you mentioned something very nice. I urge you to see my paper on SEM, and implantoplasty was the one that cleaned the surface the most. All the others did not do anything. And even we held it with the laser in our hand and holding it like this with the video, didn't remove anything when you look at it on the SEM. But bottom line is you need to decontaminate. We know that from perio, you decontaminate. If you can't decontaminate, you cannot graft. Shear's right about the membrane. It's actually complicates things because what you're saying, the flap. But I would, instead of using xenograft, and I want to urge you on that and to hear me out on that. Now you have a problem already in peri-implantitis. You went and you put xenograft and you said something, except if they don't get infections. So those patients, obviously, they're prone for inflammation unless it's a cement caused or it is plaque caused. So people with plaque is going to have plaque again. So bottom line is you put plaque in an environment that has xeno, it's the bone that grows on it is going to resorb. So what's going to happen to the xeno? It's going to encapsulate. It's going to be a chain reaction. It's been published in 2017 in JOMI. Rather, I would put what? I would put cancellous. Why cancellous? Because if there is any residual part left and you get inflammation again, it resorbs. So we don't get in any encapsulation, which increases the chain reaction of the inflammation. That's my 2 cents. I'm not going to say.
No, yeah, very interesting. And I would like to react because I totally agree with you.
Oh, thank you.
Because, you know, I mean, I've been talking about the immediate implant and there my biomaterial selection would be a non-resorbable, but for peri-implant defects or for periodontal defects, if I need to use like a scaffold, like granules, I would go for something totally resorbable because I want to make sure that, we deal with an infectious site. And there I would definitely go for, something fully resorbable.
That's a good step. I hope next time I meet you.
You see,
even an immediate.
And this is always the same story. It depends a little bit on the clinical situation, the regenerative potential, the context, and so on. Anne-Marie.
I must reply.
Absolutely.
I don't agree with you. I have worked with xenograft many years with the coral, and I have, in my experience, very good results. And I think there is a study on autogenous bone in peri-implantitis. It resorbs, but I think there will come new ones also. So I like the cork when it stays in the defect and it's healthy. And I don't agree with you. If they have plaque, they still have plaque. You saw my figures. They can brush for sure, the patients, if they are in the maintenance program and they are taught how to do it.
No, absolutely.
Yeah.
But you
Microphone.
You are in a different population. In Sweden, you have put the perio on the market and you put the 3 months recall, nobody can beat you on that. But in a different part of the world, the 3 months are going to 4 months and 4 months going to 5 months. And with COVID, we've seen catastrophe with the lockdown and the amount of disasters that we got. And that's what scares me. So there is something going to happen in their life and they're going to miss that recall. And then you're going to put an environment that might be, and I'm not going to disagree with you all the time, but it might be a problem. So that's why I try to avoid the problem, because lifestyle can change.
And I think the best way is to prevent peri-implantitis totally, because we have a problem. It's difficult to solve. So yeah, and the patient
and it starts with patient selection, right?
Yes.
Or patient motivation.
Yes.
Yeah. Okay, let's go back maybe a little bit to the bone regeneration topic. And I had another important question, I think, is how do you deal with provisionals? Alkida.
Provisionals. So it depends where we have to augment the bone. If it is posterior area, so usually if a patient is going around for several years already without teeth, so for a few months it's no problem. The biggest problem, of course, is in anterior area, perhaps. And here we have few solutions. Very, very seldom we can do it with removable dentures. Just without any pressure on buccal side, on occlusal, it hangs. But usually it's difficult part. More and more, we ask orthodontists to place several braces, a wire, and when we hang teeth on that. Or a third solution, sometimes just to take like a liner and place resin inside and like a stent. So these perhaps most popular ones. It was also cases when we just used orthodontic implants in palate and just made some customized solutions.
But so basically there are many options, many tools, but the main aspect is to not apply any pressure on the bone regeneration, right?
So I think this is the one thing where we all
agree everybody with that.
Yeah,
that's good.
Okay, good. Yeah, and what if you do a soft tissue augmentation, like only a soft tissue augmentation? Do you apply a pressure on your grafted soft tissue?
This is very, very good question. But we come back to a first case, yes, because we mentioned and we talked about allograft or xenograft. But in aesthetic area, I always would go for second grafting for soft tissue grafting and not a bone.
Yeah, let's find a case, maybe this one.
In aesthetic area, it does not matter how much bone we graft. We still need to end up with soft tissue grafting additionally. And if we have really a lot of soft tissue, we may place some temporary, but already forms our tissues after soft tissue grafting. But not in any case, in every case, not in every case, we can have already very predictable formation of soft tissue. So that's why usually also we just augment bone, augment soft tissue, and after we just try to form it.
I see.
What about
It's also a little bit like the prosthetic guides, the soft tissue healing, but you do it in a second stage. You do it like more soft tissue conditioning. Because my approach is to, the day of the surgery, to already have the ideal profile.
Yeah, you mean about immediate implantation?
Immediate implant, but for example, if I take this case, for me, I would do a stepped approach. First, a bone augmentation.
Bone augmentation, second stage implant placement with soft tissue grafting.
Yeah, in the second one.
And it depends how successful we were and what is the situation. Maybe we can place an implant, make a soft tissue grafting, and place healing abutment already in one stage. And when you have just to change to a temporary crown after. But if we need to make a second stage surgery, and sometimes the third step, like additional soft tissue grafting, and again, it may depend. Just wait until it heals and when we start to formate, or just to temporary crown and immediately form. So I have just one rule and decision making here. If I have enough soft tissue horizontal thickness, vertical height as well as keratinized and attached tissue. So I try to place as wide as possible healing abutment or temporal crown, for example. But if it is a lack of thickness, especially keratinized tissue, then I try to go for as narrow as possible healing abutment. For example, the BLT bottleneck is my favorable one. And when we elevate tissues and when we can compress them after.
And talking about the, you know, the soft tissue height or thickness, yeah, we know that, you know, the biological width is like 3 to 4 millimeters. So this is what we would want. And you show also nice cases where, you know, the soft tissue was going subcrestally to have the biological width. So what do you do in a case where you have enough bone? It's not a matter of bone augmentation, but you have very thin, and it's very often in the posterior mandible. You have like 1 millimeter thickness. You have keratinized tissue, but it's very thin. What is your approach in these cases?
Yeah, exactly. So we have all the time to think on 3 dimensions: horizontal thickness, vertical thickness, and keratinized and attached tissue. And very often lower jaw, we have very thin vertical dimension. So we have 2 scenarios. Do we have enough bone until the nerve or not enough bone until the nerve? If we have enough bone until the nerve, then we may flatten the bone or go subcrestal. Flattening, it will be like recommended when we have too much bone. Sometimes the bone grows so nicely, but if we place implant crestally, we are too superficial. And when prosthodontist needs to make like a negative angle or even mushroom on top. So that's why usually we flatten the bone, but with a flattening of a bone, we have already more tissues. And especially if you are using a tissue level implant or TLX or tissue level, so and we elevate everything. So subconsciously we thicken tissues vertically.
But it's not only a prosthetic matter, it's also biologic, you know. You cannot have a 1 millimeter biological width. So you would make put the implant deeper?
And again, if you do not go for flattening, but you use, for example, bone level implant, TLX, BLT, BLX or BLT, so we will go subcrestally. And subcrestally and removing a bone just with bone profiler, just to stay from our healing abutment and final abutment not more than 1 millimeter away. With this, we increase connective tissue layer. It will be thicker.
Okay, and what about thickening the tissues then?
And then a second option, because with this subcrestal placement, we have an increase of vertical soft tissue thickness. And when we go in a scenario, when we cannot go deeper, when we have to thicken tissues vertically, with connective tissue graft or substitute, and we have also studies with phyloderm, tutodendermis, mucoderm. We are able to thicken tissues vertically with substitutes. Of course, all tuber and palate suits as well, with increasing keratinization.
Yeah. I think what you are trying to ask him, if you have 1 millimeter of keratinized tissue, do you want to increase the amount of keratinized tissue?
I was talking, it's also a very interesting topic to address. I was talking here about the thickness, but yeah, let's formulate it differently. If you don't have keratinized tissue around your implant, if you know it, do you leave it like that or do you regenerate the keratinized tissues? Antonio?
Yeah, free gingival graft.
I'll give up.
I take 1 minute to answer this one. If I have enough keratinized tissue, I will go for mucoderm because it's absolutely enough to increase tissues vertical or sometimes horizontally for 1 or 2 millimeter, and that's okay. But if I have no keratinized tissue, then I will do split thickness flap, and I go for tuber or free gingival graft because it's able to keratinize. And when I can increase also keratinized tissue together with the thickness. This is a very important thing. We have to understand that vertical thickness, horizontal thickness, and keratinized and attached tissue, we are 3 different dimensions when we talk about soft tissue.
Edgar?
Well, it's a tough thing for me because if I grow the bone and the patient is functioning comfortably, for me, increasing the soft tissue with the free gingival graft, I'm creating a more scarring tissue than already it is scarring. And we know that the scarring tissue does not respond well. Already the soft tissue around an implant do not respond well. So I think increasing it just for the heck that we don't have it, but we have good bone underneath it, I don't think it's a good thing due to the fact we're increasing scar tissue. But if the patient is functioning and not comfortable, then yes, I will resort for increasing the soft tissue.
And also adding the free gingival graft, you don't increase the thickness because then you're splitting the flap. You just have a superficial layer of the recipient bed. Then you add a free gingival graft. So you're just creating a keratinized tissue around the implant. Stable, but it comes to his formulation, like if 1 millimeter, you have to go 2 millimeter deep. Or if the prosthetic margin should be located more coronal, you need to create a bony platform and then the soft tissue to make the ideal emergence profile.
From my clinical experience, and I don't know if there is some scientific data about that, I do a lot of epithelial connective tissue graft prior to bone augmentations. You can do it after, as you showed, but also before. And when I enter my site to do the bone augmentation, it is really thick and a lot thicker than what was grafted, because you have at some point, some kind of blood clot in between. It
grows.
Absolutely, and also over time.
It's over time. It comes twice or 3 times thicker. Depends patient to patient. So we have increasing. So is this difference between substitutes and from palate, because you have keratinization?
I would like to use my surgery on you once. So I would like to do my bone augmentation, then I rebuild everything. Then I would like to analyze the soft tissues, because when you do the surgery, like the free gingival graft or even the leave-in the epithelium, you already make an intervention. So you decrease the capacity of the soft tissues. And I really don't want to compromise prior to my bone surgery. That's why my approach is.
Yeah, these are very fascinating discussions, and I would love actually to spend the rest of the day talking about what we like to